Welcome everybody to the Wisdom webinars organized by Fascial Manipulation Institute by STECO. For us today, it's a great pleasure because we have another important member of our family. She is Colleen Whiteford. Colleen Whiteford, I introduced her, began practicing physical therapy in 1984. She was first introduced to fascial manipulation in 2014 and went on to become certified in fascial manipulation method as a clinician and instructor. She currently lives with her husband in Virginia, United States, and has a solo practice with a special focus on pelvic problems. The speech of Colleen will be fascial manipulation and menopause. I remember to our colleagues that it is possible to elaborate some questions during her speech with the question mark at the bottom on the right of your screen. So, Colleen, the platform is yours. Thank you so much for your presence. Let's go.
All right. Well, thank you, Carmela. And I am not seeing the presentation. There we go. So hi, everybody. Thank you for joining in today. And thank you to the STECOs and the Fascial Manipulation Association for this opportunity to talk about menopause and how fascial manipulation can play a part in navigating this cycle of life. And I titled this The Transition, which I'll explain more later, but that it's just part of the circle of life. And we'll see how in just a little bit. So you wouldn't think menopause is very entertaining, but actually I learned while getting this ready that it's a musical that is touring the world. It's a musical play, and it's been so popular that it even has a sequel. So who knew? Not me. But actually a better reason to talk about this topic is because different sources estimated that 1.1 billion women worldwide would be postmenopausal by the end of 2025. That's a lot of people. That's a lot of women. Whether or not that number is completely accurate, I don't know, but suffice it to say, that's an awful lot of women. And let's look at just for a moment the impact that menopause has on women. And that's a car accident behind there. We sort of skipped the crash, but anyway. So menopause has a lot of significant impacts on women with symptoms like hot flashes, sleep disturbances, vaginal dryness, mood changes, and then there's the long-term risks like cardiovascular issues, weight gain, and potential cholesterol problems. So there's a lot of serious stuff going on here. The impact of menopause was looked at in this study on women in the workplace, and they looked at 4,400 women in the workplace, and they used an instrument called the Menopause Rating Scale, which is just subjective reporting, to get their feedback on what their symptoms were like and how it might have impacted them in the workplace. So this is the Menopause Rating Scale. It has 11 questions, and it's just a self-administered scale, but you can rate from 0 to 4 for different questions that relate to physical pain, as well as vulvovaginal problems and sexual problems. It just tries to cover the whole gamut of potential problems. So the scoring is, as you can see there, above a score of 16 or equal to a score of 16 is pretty severe symptoms. And what they found was that many of the women, for average was 12. The average score for the whole group was 12. 13% had one adverse work outcome reported, and then 10% reported missing work, and that was at least 3 days for the year because of menopause. And so understandably, the odds of reporting an adverse work outcome went up as their score went higher, which is easy to believe. So ultimately, they estimated that an annual loss of $1.8 billion occurred in the United States based on menopause symptoms. And that's not small change. But, you know, it's not just a problem for the employer or for the gross domestic product, because the woman is also going to suffer with this, and not just physically, but even financially. So if you think about it, at this stage in life, a woman has probably been at her career for a while. She's been advancing in her profession. Now she's having to deal with added stressors of not being able to sleep well, maybe having more pain, having cognitive, emotional issues that other coworkers, like younger women or male coworkers, don't have to contend with. And it can make it very hard for a woman to continue her performance level, maybe even to be able to continue to remain in the workforce at all, depending on the severity of her symptoms. So it can be hugely impactful for a woman. So on top of that all, complicating this is the fact that many women at this point in life, whether they're working or whether they're not, they're also trying to juggle with aging parents. They have children who may still be dependent on them. They're trying to run a household. And there's so many other stressors on top of them trying to work or not work, but dealing with loss of sleep and these other bodily changes, especially if they don't understand what's going on. So there's just a lot loaded on. Compounding it even further is the fact that a lot of, I can't get this slide to advance. It's just kind of stuck here. Okay, I'm going to back it up a little bit because it missed a couple. So making it more complicated is the fact that, and I didn't know this, most professional clinical training programs of any sort, be it physical therapist, physician, they don't learn anything about menopause. And I was really surprised at this because I thought OBGYNs for sure would have more training in menopause. And an OBGYN physician who was speaking at a webinar that I participated in said they got very little to no training at all related to menopause. So it can really make a woman feel unsupported because the person she's going to see doesn't even have any training or isn't able to prepare her for what she can expect in the future. So this was a survey done of women. This was in the UK in 2023, where they surveyed women and said, you know, how informed were you about menopause? And they were in their 40s, and 49% said they were not informed at all. 45% said a little informed, but the point is they were really not prepared. And that's, again, a reflection of because their providers weren't prepared. So this article just showed the value that perhaps a little bit of education and information provided to women can offer to them as they go through or approach this phase. And these were some of the quotes from it, that research suggests that specific programs can support and enable women to handle these transitions, and that the menopause health education improved quality of life and symptom control in menopausal women. So just some information, something as simple as information can be very helpful for women. So my objectives in presenting this at this time are, as you see here, first, let's look at myths and hype surrounding the menopause transition and replace them with some facts and science, because facts and science can go a long way to mitigate distress and fears. Secondly, I want to describe common symptoms of the menopause transition and the physiologic processes driving them, because if you understand what's driving it, and maybe it can help also direct the care that's going to be the best. And then thirdly, identify evidence-based treatment options to improve the quality of life and function during the menopause transition. There is a lot that can be done to help women in this time frame, and I think we all could be more aware. I have learned a lot just by getting this ready. All right, so this is me. I'm a board-certified specialist in orthopedic physical therapy in the United States. I'm certified in trigger point dry needling, as well as in fascial manipulation, both as a clinician and as an instructor. And there's my contact information. I have a website that's loaded with fascia information. And these are some of the fine organizations that I belong to. My most recent membership was to join the Menopause Society. You don't join the Menopause Society by going through menopause. It's actually a not-for-profit organization of multidisciplinary professionals, healthcare professionals who are just interested in helping learn more, or helping women by learning more for themselves, and then being able to offer resources to help them through the menopause transition. And this society has over 10,000 members in it. I had never heard about it, but I was so impressed with some of the materials and what I saw them doing that I joined last month, or 2 months ago. So it's a good organization. You might want to check it out. So our culture can really make a woman feel kind of like this burn up, dried up forest here. I mean, we have so much emphasis on youth and beauty and vitality, and reproductive years, and that it's also, that's what's the paramount of life. And it can really make a woman going through the menopausal transition feel like she has no value, no worth. She's not beautiful, she's not vital anymore. But I just like to suggest that maybe we just need to look at this a little bit differently, because I see the menopause transition as something more like just, it's a phase, it's a change, it's a different season in life. And I think autumn is one of the most beautiful seasons in life. So I'm trying to think of it more along that way and hope that that comes through. So when we say the word menopause, a lot of people don't really know, what are we talking about? Yesterday, I was at a luncheon where I told I was going to be doing a menopause seminar this Saturday, and one of the women came up and just said, I don't know if I'm in menopause or not. And I thought, well, you're probably not. You're probably perimenopausal, but it's a little bit hard to know. So let's just look at a definition. So if we go to the dictionary, the menopause definition is the period in a woman's life, which I thought was a rather odd choice of words to use, typically between age 45 and 50 when menstruation ceases. Now, I would suggest that it's probably a little more complex than that, and we can go a little deeper. So it's a natural stage of life. It's not a disease. It occurs average around 51 and a half, but it varies. The hallmark is the cessation of ovarian function and a large decline in estradiol, which is a type of estrogen, and it's typically diagnosed retrospectively after there have been 12 consecutive months with no menstrual period. So if you go 11 months and then you have a period, you would be considered perimenopausal. But at that 12th month with no period, there's 1 second where you realize it and you go, oh, so I'm menopausal. And then at that moment, you're postmenopausal. So it's really just about terminology and kind of semantics. This was part of the presentation that I did in December through the International Pelvic Pain Society and the APTA pelvic health section. And Dr. Weitzman was presenting on this timeline that I really liked the way it laid out. So if you look to the left, you can see that the changes in periods can start even in the 30s for women. And then the changes in the periods may continue, but the symptoms then start moving more into being perimenopausal with maybe hot flashes, mood swings, trouble sleeping, stuff like that. And then when you hit that 12th month, it's menopause, and then you become postmenopausal. So this whole transition can vary in how long it takes, but for most women, it's roughly about 10 years, but it can be quite variable. But my point with this is that this isn't an old woman thing. I mean, I just said we start having these changes even as early as the 30s. And some women, if they had a surgery or something else, some other reason, they may start menopause very early in life. So the hallmark of the process is the decline in estrogen. Estrogen is the general term for the female sex hormones. Estradiol is the most prevalent and potent one. And if you think about it, estrogen could be termed like fruit, and estradiol is more specifically like apple. I think of estrogen something like Wonder Woman, and it does an amazing array of functions in our body to keep us healthy and the way that we are when it's in higher levels. So it serves as a neuroprotective modulator. It does all kinds of functions in the body that help the brain function better, the heart function better. But one of the things I want to point out is that it's a neuroprotective modulator, and it's looking at and assisting and supporting very important neurotransmitters, like acetylcholine is one. And by review, if you look at all these functions, these are important. Memory, learning, attention, focus, moving, breathing, sleep, autonomic nervous system functions, digestion, so many vital things to life. Serotonin is another one of the neurotransmitters that estrogen supports. Stabilizes mood, emotions, sleep again can be supported. So you're starting hopefully to see why in the menopause transition, women can really struggle with quality sleep, and a pain modulator. And another neurotransmitter that estrogen supports is dopamine. And this neurotransmitter drives motivation, cognition, complex functions. It supports the blood vessels, insulin. It's our feels good reinforcement neurotransmitter. We also have these changes that are visible in the brain that affect the hippocampus, which deals with memory and learning, and the prefrontal cortex, which deals with focus, planning, and emotional regulation. So looking at all of these changes, it's easy to think for a woman that she's maybe becoming like declining cognitively or getting dementia, but it's really just about disrupting neurotransmission. It's not as much about cognitive decline. So one of the pieces with my menopause seminar that I watched in December was they gave us access to this documentary called The M Factor, Shredding the Silence on Menopause. It's excellent. It's not free open access, but if you ever have a chance to see it, I really recommend it. But one of the visuals that struck me was showing some brain changes, both before and after menopause, just because of the support that can come from estrogen and those declining levels. And there's a dip during perimenopause. We recover and resume, but it really is about just the ability of estrogen to support the function of the brain. So it's not hard to understand how mood swings and just emotional changes can really be part of what women are experiencing through the menopause transition. So another change that can really become impactful is the changes with the hypothalamus, because the hypothalamus is our thermal regulator in the body, but it's very sensitive to fluctuations in estrogen. And so naturally, this can be where a woman begins to experience what we call the vasomotor symptoms of menopause. So the vasomotor symptoms can really be severe for some women. For others, they're just bothersome, but it can be life-altering if it disrupts sleep. Once again, another aspect that can disrupt sleep, as well as if it interferes with her ability to function in the workplace. And these symptoms can last anywhere from 5 to 10 years. On average, a lot of women have them for 10 years. That's a long time. So another amazing function that estrogen does for our body is it helps us with metabolism and weight control. And the metabolism slowdown is basically a reflection of estrogen. So estrogen helps regulate metabolism so that even if you're eating the same, you're going to burn fewer calories at rest, which is a no-brainer for it's going to be easier to put on weight with the decline in estrogen. There's going to be an increase in appetite because estrogen influences hunger hormones. It makes it harder to not be eating more. Another function that estrogen does that can influence the weight is insulin resistance. So the hormone shifts make the body less sensitive to insulin, and it causes fat, instead of being stored at the hips, to be more likely to be stored on the torso. And it's more of a visceral fat instead of the adipose that's typically on women in the hips. And it's referred to as the menobelly, which I think is kind of annoying, but I didn't make it up. And another aspect of it is that estrogen maintains muscle mass. So sarcopenia, the loss of muscle with aging, is going to be a part in weight because muscle burns more fat than weight does. So when you put all of these together, it's not hard to see how a woman can really struggle with weight control. Another aspect of weight control is reflected in sleep. And if you're not getting 7 to 9 hours of good solid sleep a night, it disrupts, again, these hormones that deal with metabolism. And if you've got a woman who is dealing with night sweats, hot flashes, who has to get up frequently in the night to go to the bathroom, which interferes with sleep, but also if it's a woman who's dealing with musculoskeletal pain, you put all that together and sleep disruption can be a huge problem. So another aspect of what estrogen does to protect our bodies is what's called the genitourinary syndrome of menopause, because estrogen really protects the genitourinary structures and tissues in a woman's body. So the declining estrogen levels can lead to what all of this is called GSM. Now, I will say that a lot of these symptoms I've treated for years in women who are well before they approach the menopause transition. So these are not just unique to women in menopause, but you can see there's a lot of very troubling and disruptive symptoms that can manifest related to the tissues. And what one function of estrogen is that for the vaginal epithelium, it helps maintain its thickness, but also its circulation, the collagen content, Whereas postmenopause, with the decline in the estrogen, the epithelium gets much thinner and more fragile. It's just not as robust. And this paper by the team at the University of Padua looked at that and found that with age, women were more likely to produce less collagen 3 in their tissues and more collagen 1. And this is significant because the collagen 3 has more elasticity. Collagen 1 does not have as much elasticity to the tissues. Now, this can affect the vulvovaginal tissues, but it can also affect the entire musculoskeletal system, which is another role that estrogen plays, is protector of the musculoskeletal system. And musculoskeletal syndrome of menopause, I think, is our last abbreviation with this whole construct, the MSM. And this can be a huge factor for a lot of women with pain. So this Chinese research team looked at some of the symptoms and the impact that it had on women for the musculoskeletal components, and found that 71% of women in midlife experience musculoskeletal pain. 25%, it's severe. 40%, they have no significant structural abnormal findings. So there has to be another explanation for it. Here's another paper from the team at the University of Padua, and they were some of the first to recognize that the tissues have hormone receptors and that the fascia is sensitive to estrogen and relaxin, and that these declining levels could be a factor and maybe an explanation for some of the musculoskeletal pain that women experience more than men, but even more so for women in the menopause transition. So another role that estrogen plays for us is protecting the hair, skin, and nails. And we don't have an abbreviation for this one, thank goodness. But this paper that's coming up looked at what's the impact on this with the dermatological changes related to menopause for women, and found that 50% of women experienced severe changes. It was severely distressful, and nobody ever warned them that this would be coming as part of the menopause transition. But as I looked at earlier, that's not surprising because a lot of clinicians themselves don't know what to expect. So the last role that I'll bring up about estrogen in this whole model is that it's thought to be influential in mediating inflammation, but it's a complex construct and it's not entirely understood because there are some aspects of estrogen that seem to be pro-inflammatory and other aspects that seem to be anti-inflammatory. So we don't really understand that role of it yet, as well as we understand some others. So it might seem like, well, this is a no-brainer. Hormone replacement therapy would take care of all these problems, but it's not that straightforward. It's not that simple. So the Menopause Society has proposed changing it from the term hormone replacement therapy to menopause hormone therapy, because we're not trying to replace all the hormones that we were making in our 20s, but only some of the decline in the estrogens since the ovaries have stopped producing so much. I'm going to be sticking with the HRT terminology because I'm more used to that and the literature is more full of that. So for the rest of the presentation, I'll still call it HRT. So HRT is not new. Surprisingly, I learned it goes back into the 1800s, but it became commercially and more widely available like around 1940 through 1960 when formulations like Premarin became available. In the 1990s, it was extremely popular, and many women used these hormones for helping to mitigate the symptoms of menopause. Well, this all came to a screeching halt around 2002 when the Journal of the American Medical Association published this study by the Women's Health Initiative. And this was a study that had federal funding, but they were looking at the women's response to the use of one specific systemic oral estrogen compound. And the study was slated to be, I think it was supposed to be 8 years. It started in around 1995. And they had a large group of, they were actually like 63 years old and older, but they were administering oral systemic hormone replacement therapy with estrogen for these women. Now that's, first I'm going to say, that's usually older than what the guidelines now say they were supposed to be administering it. It would have been more successful in a younger population. But nonetheless, ultimately the study was halted because the women developed so many health problems that they just decided this is not worth it. There's more risks than there are benefits. And so they completely halted the study. And a result of that, the FDA slapped a black box warning on all estrogen, not just the kind of estrogen, the oral systemic that the women were using in the study. They put it on all forms of estrogen, including topical local estrogen cream, which was never even used in the study. So it was a pretty severe response. But the response then was pretty severe throughout the world because they went on to publicize. Oh, we're stuck on this slide. Sorry, try to back it up. There we go. The publicity surrounding this and the press conference that they did in July of 2002, it sent shockwaves all over the world as they drew a correlation between taking these hormones and developing breast cancer. And it rocked the medical community. It also rocked a lot of people who were successfully taking these hormones. But a lot of physicians stopped prescribing them. A lot of women stopped taking them, and a lot of women were afraid to start taking them. And I was one of them. It was around 2012. I was prescribed estradiol when I was probably about 50 years old. I needed help with some symptoms I was trying to navigate. But every time I took this, I kept wondering in the back of my mind, am I increasing my risk of breast cancer? And so I just decided I'd rather live with my symptoms than live with the chance of breast cancer, and I threw it away. So year after year, many societies, including the Menopause Society, protested the black box, citing the poor science, the fact that the women were older than the normal hormone replacement therapy population should be. They said they were overlooking the benefits for osteoporotic fracture prevention, and they also possibly cardiovascular. And the literature kept pounding out arguments against what was going on with the way they were approaching the black box and putting that on there. The FDA continued to ignore expert testimony, but the battle raged on in the literature. And they finally did a repeat study where they really did bring out more of the research showing the benefits of the estrogen replacement. So this paper then finally in 2024 just cited that how damaging that Women's Health Initiative results publication was for women with symptoms, but also for training of practitioners in the management of menopausal symptoms. So finally, just last fall, the FDA reversed its application of the black box warning, and it took all warnings off all forms of estrogen, oral and local, whether it was systemic or whether it was local, which was a pretty severe move in the exact opposite direction. But as a result of 23 years of this black box on it, very few women in the world are accessing this. So where does this take us? Well, at the moment, I think it's safe to say, I know it is, local estrogen is a safe and viable option for most women at any stage of the menopause transition to help with the genitourinary symptoms. Systemic therapy should and can be considered at any age for symptom-appropriate women in the management of symptomatic symptoms and maybe to prevent osteoporosis. But finally, estrogen isn't going to cure everything. It's not the fountain of youth. It's not for everyone. So another function, oh, I'm sorry, I forget I don't have my notes. So if we don't just look at estrogen, but it's nice to go, well, what else can we do to help women through this time period in life? And this is where I really want to highlight what fascial manipulation can do. Estrogen is wonderful, but in the clinic for me, my go-to for helping women, especially, but people of all ages and walks of life, to manage their symptoms is using fascial manipulation and my tools with my elbow and my knuckles. So let's take a look at how FM can help first with the management of the vasomotor symptoms. So this is where the systemic doses can help. So this would be oral or maybe transdermal patches, but this can help with the vasomotor symptoms of menopause because it has an impact globally and widespread throughout the body. But fascial manipulation can also help by opening up pathways where blood vessels are struggling to pass through dysfunctional fascia. and they are working harder, so it can raise not only the blood pressure, but it also can make the body less able to adapt and change thermal regulation according to the circumstances. So FM can be very helpful for opening up key blood vessels. And we follow a particular pattern of deep fascia, addressing where the deep fascia has become densified and stuck together. So we're trying to take it from the construct on the, I don't know which side of this, I guess that's the right side of the screen, from B to A, but we're particularly interested in very specific points that relate to the blood vessels. So there are very certain patterns of points that fit together to open up blood vessels, where we try to move the construct from densification, where next to the blood vessel, the fascia is compressed and stuck together, and try to restore that space and slide so that the blood vessel, as it moves through, isn't struggling so hard, and then vasodilation and vasoconstriction can occur more normally. Now, another element in controlling vasomotor symptoms is weight, because weight and adipose are insulators. So these two are really problems that coincide to each other. So what we look at here then is that we really have two levels that we can work at for addressing vasomotor symptoms and weight gain. We can work at the superficial level, and here I'm looking at doing fascia manipulation with the adipose at the surface, but also trying to break up what's stuck together in the hypodermis. We're potentially impacting the autonomic nervous system. We're opening up the tissue so that the blood vessels, again, can vasoconstrict, vasodilate more appropriately to help with vasomotor symptoms. Cupping can also be very nice for helping with that. And I want to acknowledge that the scraping tool in the middle can be wonderful, and I thank Warren Hammer, if he's watching, for opening my mind and my practice into that and the possibilities of that. And Larry Steinbeck was one of the first ones I saw demonstrate cupping. And I've brought both of these tools in with nice results for vasomotor symptoms, as well as aiding in weight management. So what I'm showing here is I teach patients how they can work on themselves. So the one photo I've got, the woman working on her own shearing in the hypodermis to try to help break some of this stuff up in a faster way. If it's up to me once a week, it's going to take forever. And I also teach patients how to use cupping to help. So in addition to working at the surface for vasomotor symptoms and weight, we're also going to look deep, and we're going to be addressing the deep fascia as it relates to the organs of digestion, as well as the deep blood vessels, but also so we'll be impacting circulatory as well as digestion with both of these techniques. And it's really not the problem in the organ with the stomach. The blood vessel is not the problem. It's got more to do with the environment that the structure is trying to function in, the fascial environment, and normalizing that. A lot of people just focus on nutrition and exercise as being the only elements or pillars of weight loss and control. But I would suggest there's a whole lot more to it than that. And I laid this out for a different talk at one point. I give it 6 pillars. Nutrition and exercise are important. So are rest. We talked about that a little bit. Emotions and environment are also important for weight loss and control. But I think ignoring what the fascia can do and the influence it can have on weight loss and control is huge. Most people never look at or consider or understand what attention to the superficial fascia and hypodermis and the deep fascia can do to aid in weight loss and control. So let's look now back to these genitourinary symptoms and what fascia manipulation can do for these. So, gosh, it gets a little hung up on changing slides. So when we talk about libido, because that's one of them on there, you know, libido is pretty contextual at any phase of life. And there are a lot of factors that can influence libido. Certainly what's happening in the genitourinary tissues can influence it. But again, a woman can have pain with intercourse at practically any age. It's not just a menopause problem, although it can get worse later. But it's just good to consider that this isn't all about estrogen. A lot of other elements can play into that. But so, yeah, when there is this pain with intercourse, that's, of course, it's going to influence a woman's desire and you know, eagerness to participate in intercourse if it hurts. So we can do a lot though to help just with that, but also all of the elements that the genitourinary system is struggling with. So this is where the local cream could be more helpful. And it's not just cream, even there's rings, there's tablets, there's lots of different formulations, but the local symptoms of the genitourinary are usually managed best with the local agents. And these are some of the symptoms that the local agents can help to manage. Oh, well, this thing wants to get stuck. Okay, well, we'll go back. So I circled these because this is what the local agents may be able to help with and are good to be open to. Then there's other things though that like the silicone and oil-based, but lubricants and moisturizers can also help with some of these symptoms. And these are some of the symptoms that I've circled that I think the lubricants and the moisturizers can be more helpful. And you can use both the local estrogen and the lubricants and moisturizers together. And you can also use them along with the systemic estrogen. So looking at these symptoms, I just circled the ones that I think that fascial manipulation can really be helpful with. And if you notice, I circled all of them in the urinary because I find fascial manipulation to be especially helpful in that category. And it's back to that environmental conversation, whether this water balloon represents the bladder, the uterus, the ovaries, the stomach, it doesn't matter. But whether the rubber band represents fascial densification, it's restricting the organ. So it's really not about the problem in the organ. It's more about the environment surrounding the organ and allowing the organ to be freed up so it can function properly. So when it comes to pelvic problems and especially genitourinary symptoms, the lower limb is a huge element in this. And I say I never treat a pelvic problem without doing some work into the lower limb. And in this model, it's called the distal tensor. So with fascial manipulation for these symptoms for women in the menopause transition, but really for anybody, we begin with a really thorough medical history that takes into appreciation all past problems, and especially the ones that might involve old resolved issues in the lower limbs. I really pay attention to old ankle sprains, and I specifically ask about these because people forget. I ask about plantar fasciitis, shin splints, heel pain, even restless legs or growing pains as a kid. I want to know about all these because that lower limb is really going to be part of the treatment plan for resolving these symptoms. Then the next step would be if there is movement dysfunction, I want to be able to identify it because it might give me a direction sense of where do I need to be working on this person, but also it gives me something that I can check afterwards to see, did I make a change with the intervention that I did today? I like these three movement verifications. They're quick, they're simple, and they're objective. So I'm looking at hip external rotation with a goniometer. I'm measuring squat range of motion, and I use a tape measure going from the ischial tuberosity to the floor. And I also do trunk forward bending, just measuring how far are the fingertips from the floor, and then I'll recheck it after the treatment. So I'm really interested in lower limb but also in the trunk and looking at all areas that may be influential. But now my next step is going to be palpation verification, where I'm feeling for where have we lost that slide? Where is it painful, but where do I also feel it densified? And where do I need to be targeting my treatment? And then in treatment, I'll use my knuckle, I'll use my elbow, but I also like to use other tools. Like I got pictured there, a vibration roller, which is nice for kind of distraction, maybe while I work on another part of the body, but also for sort of prepping an area where I might be going to next that's in the torso. I like using the percussion devices when that's appropriate because it gives me a break with my hands, but it also gives the patient a break from just the discomfort that fascial manipulation can bring out with treatment. I use dry needling also in some situations, and I may be dry needling on a fascial densification point. And that blue triangle in my hand on the foot is a 3 tool. It's the number 3, TOOL. It saves my knuckles for some places. So I use it as needed, or I have patients to get them. So I can have a great impact on the pelvic floor tissues without ever touching the pelvic floor through this model because of the continuity of the tissues, the relationship of the connective tissue from head to toe, and making a change in one area can impact another. And this was from Carla Stecco's work showing the deep fascia of the external oblique and how it's continuous from the trunk and crosses over into the contralateral lower limb. And she said this fascia is also in continuity with the fascia of the pelvic floor. These images just help us see how complicated this area is, but also how continuous it is with the trunk in the front, in the back, and down into the lower limb. And I want to thank Larry Steinbeck for helping me put my hands on these pictures again. But it's good to recall that if the muscle spindle or the Golgi tendon organ are embedded in a non-elastic matrix, fascial matrix, then it doesn't matter how much we stretch, how much we strengthen, that you're not going to be able to change the construct until you make the environment surrounding the neural elements more normal. So in the research, we see this correlation or this construct supported of a relationship between the lower limb and the pelvic region. And we also see it in the clinic. This was a nice case report by Marco Pintucci, one of our instructors, just looking at the benefit of fascial manipulation used on urinary symptoms. And this was an older study from, I think it was 2016, that another teacher, Andre Piscini, did, showing nice response working in the trunk and the lower limb on pelvic pain, but also on knee pain for this client. So I'm just going to mention briefly that estrogen isn't the only hormone to consider that is a problem with the menopause transition, but testosterone decline is also. And if you look at all these symptoms that are under the blue side, which is talking about problems related to lower testosterone, it's quite remarkable how much they mimic the estrogen symptoms. Now, in the United States, well, I'm going to talk a little bit about just testosterone in general, but it's not a new hormone by any means. And the symptoms that are trying to be managed are aimed at decreased libido, erectile dysfunction, infertility, hot flashes, depressed mood, and loss of muscle mass or hair. Now, this is talking about, these are clinical studies on men. And this paper goes back to 2016, and they said this stuff has been looked at in practice for men for 70 years. Now that's 10 years old. So research on testosterone replacement for men goes back 80 years, whereas there's none for women. There's none. In the United States, there are no approved formularies for women. So doctors prescribe men the dose they would give a man and just back it down. It's not approved by the FDA, so a woman has to pay out of pocket for it, and then also has to pay out of pocket to go be tested and make sure she's not being overdosed on it. So it's a little lopsided, back to our FDA, but there are 3 countries, you see them there, where there are formularies for testosterone cream for women, but we don't have it in the United States. It's not very common throughout the world. But I just want to comment briefly on how much good fascial manipulation can do for these musculoskeletal symptoms of menopause, but of any phase of life. But the women going through the menopause transition are so susceptible to widespread symptoms that maybe they had before, and they're worsening in this phase. And fascial manipulation can really be helpful for either diminishing or resolving so many of these. Now, this is another place I'll just comment on the potential benefit of systemic estrogen, because it factors into bone health. And when it's administered early in the perimenopausal phase, which would mean maybe age 40, where a woman is still having periods, but they haven't completely ceased, it can help diminish the future bone loss. So women generally will lose about 12% of bone loss by the time they've moved through the menopause transition. What the estrogen replacement does is it helps decrease that for a lot of women, but it needs to be administered earlier in life, like before 5 years or so. And then after the menopause finally sets in and they're postmenopausal, you have about 5 years, and then it's probably not going to be as much benefit for this purpose. So we can't get all our estrogen back and support these wonderful neurotransmitters, but I hope you can see how all these other elements brought into play could at least decrease the impact that is happening to our loss of estrogen on these things. Our FM and other interventions can help support sleep, which is a huge one. and modulating pain, which would help anybody feel better and feel more stable emotionally, be able to focus better. And we have tools that can help with this, even if we're not talking about estrogen replacement. So, big impact, a lot of these things, but I hope you can see that we really can help these symptoms. And especially with a tool like fascial manipulation for managing the vasomotor symptoms, for the musculoskeletal symptoms, for the genitourinary symptoms, we really have a lot to offer for women. And it's not just something where they just have to live with it and get through it. And I hope you can see the potential and just think about this a little bit differently from hearing some of these interesting facts and studies. And thank you. That's the end. All right. Thank you.